going back to the previous uh, essays in larynx and pharynx, I think we framed some structure for each and every questions. So we'll be just going through it before getting into the nutshell of the ENT essays. Okay, so just a minute. My system is getting slow. I don't know why. So kindly bear with it. Okay. So yes, the questions will the questions will be from anatomy of the nose, might be the lateral wall of the nose or the paranasal sinuses. Okay, or it might be about a disease or a condition, or it might be a surgery or a procedure. It might be an investigative procedure or a drug. So we can classify the questions under these. These have been discussed earlier in the previous presentation, but in spite of that, I just want to emphasize you and just check on the framework for each and every questions. If it is an anatomy, you have a set of subheadings in which we have to work out, and if you study in this manner, it will be very easy to reproduce also. So if it is an anatomical question, then if it is about any muscle or if it is a nerve or if it is an artery, then you have to just go back to your first year and think that you are writing an anatomical question where you have the origin, insertion, the boundaries, the divisions of that structure, and the contents of the structure, if it is a space, and then the significance, the applied anatomy, the surface anatomy. And don't forget, for every anatomical question, you have to give a diagram. Diagram is of utmost importance. Even if you are bad at it, please go with a diagram. Okay, your diagram usually carries a good amount of point. If you are, like, for example, in uh, DNP exams, um, you will get a question exclusive for a diagram, right? Like when I was appearing for a DNP exam in my post graduation, uh, I was asked a question about draw a neat labeled diagram of a right tympanic membrane with a grommet. So that's what the question is. So the whole question carries 10 marks out of 100. So imagine the importance to the diagram. So whenever you are asked any anatomical question, try to draw a diagram. Anatomical question warrants a diagram. So uh, please do that. And then we go with the other thing is the disease or the condition, or the if it is a disease or a condition, remember this structure, give an introduction, give the incidence, like in which sex it is more common, and with which age group or in which geographical location it is more common. And then comes the etiological factors, the pathogenesis, the clinical features, the signs and the various symptoms, and then how you go about investigating it to give the diagnosis, and then the treatment part. And if there is any rehabilitation and prevention measures, yes, you have to add that too. So if you read everything in this manner, then it will be very easy for you to reproduce. Like, say for example, if you have a question about allergic rhinitis, then you can imagine what is the introduction like. Introduction will be, what is the disease about? It's an allergic rhinitis. You have to give some introduction part about that incidence, who it may affect, male or a female, both common to both, which age group it can affect, the pediatric population also, and most commonly with the uh, middle age group people. And then with the etiological factors, what are the etiological factors, and then the signs and the symptoms you can elaborate about. So even if you don't know about the disease or the condition also, even if you know very less about that, you can put your points in such a way that you give a brief and a detailed explanation over the questions. So if you are asked about a surgery, then surgery has its own indications, contraindications, complications, the three major subheadings of the surgery. And to get some extra points, you can put on the history of the surgery and then some variations of the surgery in today's time. And then if it is an investigation, the same thing, the principle, procedure, and the results. And if it is a drug, go back to pharmacology, introduction, mode of action, indication, contraindication, and the side effects. That's it. But in nose, we don't have any questions about the drugs. That's what over a period of time, I went through those 10 years of question papers in the last 10, previous 10 years. So I didn't find any question on drug, uh, especially concerned with the nasal cavity or the paranasal sinuses. So the most favorite, I would say, the most frequent and very repetitive question was the lateral wall of the nose. So we are starting with the anatomy, so I just thought that we'll go from the anatomy and then the disease and the condition and then the surgery. Investigative procedure, not big, many the nose, except for diagnostic nasal endoscopy, can be used as a can be asked as a question, and rhinomanometry. But usually, I didn't find any for undergraduates question paper having asking about rhinomanometry. But yes, postgraduate students of ENT, they do get this rhinomanometry question. So lateral wall of the nose was very frequent. I think it was asked and repeated for last in the last 10 years for 3 times, I hope, in the Tamil Nadu paper. And I don't know about the rest of the India, but this is really a topic on its own, and it is a very repeated topic. Even if you are not asked any question in as an essay, you would be asked about the lateral anatomical landmarks of the lateral wall of the nose, as one or two landmarks can be asked in the short notes also, like osteomeatal complex can be asked as a separate short note, or an eustachian tube or a fossa of Rosenmuller can be asked as a 2-mark question or a short note. So you have to prepare it in that way. It's not preparing for the essay as a whole. The essay encompasses many short questions within itself. So if you are preparing for an essay, you think that you are preparing a topic, not a topic, it's a chapter, so that you are able to make one essay and some 10 short notes from that. So that's how it is. So we'll start with the anatomy, and I'm just briefing about the essays here. I'm not giving a detailed explanation about each and every topic. And mind that, because I think I was told that this was a revision, and this is just to make sure that how to go about in preparing your for the exams, and how to score good marks, and how you are going to carry out this ENT in the coming months. So uh, it's not a typical lecture where I can elaborate on each and every topic. It is very time consuming. So I will be just giving hints about how to go about with this question. That's it, and we are just going to revise it faster. That's all. So one or two questions I will be dealing those important questions. I will be detailing it, but the rest of the things, rest of the questions, I had just mentioned it so that you go and prepare on your own. Okay. So the lateral wall of the nose was very frequent, and once you think of it, what are the subheadings you get it? So the introduction part, what comprises of the lateral wall of the nose, and what is the function of it? So usually the function is the olfactory function, which is at the roof of the nose, at the olfaction area, and then the vestibule of the nose, which has hairs and which plays a vital role in humidification and also in preventing the foreign body entry. And it acts as a filter so that the particles get settled there or filtered before entering in through our nose. And then the major part of the lateral wall of the nose functions as the respiratory region, and the posterior part belongs to the nasopharynx with the eustachian tube opening, which is very essential to maintain the modular and the atmospheric pressure, creates a balance of it. So that's the function of it. And if you want to be an elect student, then you can even give a subheading of development. So any anatomy starts with embryology. So you can give a hint about the development of the lateral wall of the nose, the olfactory pits, and the development of the face from the six pouches and the other things. So you can just put a word on it from the development, the nose developed from so and so, where it aligns to form the midline from both the sides, and then you can carry on with that. And then comes the concha, or you have three concha, the inferior, middle, and the superior. Sometimes you may have a supreme concha above that, and then comes these concha, inferior turbinate is a separate bone, and whereas the middle turbinate and the superior turbinate are part of ethmoidal labyrinth, and then comes the meatus. So below each concha you have the meatus, which forms the space: inferior meatus, middle meatus, superior meatus, and so the inferior meatus, what opens into it is the nasolacrimal duct, and into the middle meatus you have the maxillary sinus opening, the osteomeatal complex, where the anterior ethmoidal cells opens into it, and then the posterior and then the superior one, where the opening of the sphenoid sinus, the sphenoethmoidal rhesus, and the posterior ethmoidal sinuses opens here, and the frontal sinus opens through the frontal rhesus into the middle meatus. So you can separately give a heading on concha and then the meatus, and then mention one line. The whole you can write it for a 2 pages easily, and then comes the blood supply. So what is the blood supply? From both the compartment of the internal carotid system and the external carotid system. From the internal carotid system you have the anterior ethmoidal artery, which enters and supplies the roof and some part of the lateral wall, and then comes the sphenopalatine artery and the greater palatine artery, which forms which supplies the major part of lateral wall of the nose. The posterior ethmoidal branch is also supplies a part of the posterior lateral wall. So that's the so going back, we have we finished with the introduction, the functions, the development. So if you have a if you think that you are going to um, forget those subheadings, I would request you to just you can write these subheadings on the right side, right column, or you immediately once the question you write the question and then you list out the subheadings, and then you can start with detailing with every subheadings, because that gives a very good presentation to the paper so that you can follow it on. So the examiner in the once he starts takes the paper and just sees the paper, immediately he will look at the subheadings you have given, and he will think, yes, he gets a good impression that yes, the student is going to give a good answer. So the rest thing he is just going to walk through your subheadings, and if you had written just 2 3 points below every subheadings is going to give you a good marks. So that's how the presentation will look like. So you can enumerate those subheadings once you start the questions. That gives a very good impression to the person who is correcting your paper. So that's it. So you can give a um, heading as a eustachian tube orifice. You can very well think that why in lateral wall you have to give that, but posterior part of the lateral wall you can give you can write about the eustachian tube orifice, and you can even write about the force of the Rosenmuller, which is the origin of the nasopharyngeal carcinoma. Then you can give some mention about the relations of the lateral wall, like medially it is related to the nasal cavity and the septum, laterally it is related to the maxillary sinus, and superiorly it is related to the orbit and the roof of the roof of the nasal cavity, the olfactory region, and above that is nothing but the cranium. So posteriorly you have the nasopharynx. So you can very well give the relation. So the if you find that you are writing less, or if you have some time to complete your exam, so you can elaborate on that relations also. So that's how the lateral wall of the nose goes on. And most of the time, the lateral wall of the nose is asked in a very, very detailed manner. They ask you about what is the blood supply. They, they specifically ask you. write a note on the concha and the meatus, write a note on the osteometal complex. So you know very well to what to write. So the next repeated and very important question was epistaxis. Usually the question starts like this. So what are the causes of the epistaxis? And or sometimes it might be a case history. A 6-year-old child came with epistaxis and how you are going to manage it. So first, whenever you are given a case, just brief about, write a brief mention about the case. So if it is a 6-year-old patient with an kid with an epistaxis, then it's mostly a trauma. It's a very common thing in children in the pediatric age group. If it is an adult, then you think about any systemic diseases or uh, or any mass lesion. So even if it is a teen, if it is a teenager, then the epistaxis is mostly due to juvenile nasopharyngeal angiofibroma. So the second part of the question will be about the juvenile nasopharyngeal angiofibroma. Sometimes, if yeah, the other most common um, cause of epistaxis is rhinosporidiosis, which is very common in Tamil Nadu. So in the southern states of Tamil Nadu. So you may be asked about rhinosporidiosis also, and that's how the question was framed. That's what over the period of years they had asked. So if you are asked about epistaxis, just imagine these subheadings. So if you are asked about epistaxis, then write a brief introduction and anatomy of the blood supply. It is very important so that you write about the Kesselbach's plexus or the Little's area. Little's area is usually of the septum, not the lateral wall, and posterior epistaxis, which is due to Woodruff's plexus, which is the posterior part where the spinopalatine artery anastomosis with the part of the pharyngeal artery. So, Kesselbach's plexus or the Little's area, the pneumonitis gas. That's what I remembered when I was a undergraduate. Greater palatine artery and anterior ethmoidal artery, spinopalatine artery, and superior labial artery. So that part of the Little's area is an anastomosis where both the internal carotid and the external carotid takes place for anastomosis in it. So write a brief mention about the anatomy and if possible draw a diagram of this Little's area and the Woodruff's plexus so as to impress the examiner. And then you can go with the etiology. Etiology, you have so much. The etiology of epistaxis is very vast. You have two types. One is the local type and another is the systemic type. Okay, so any local causes starting from trauma and barometric changes, pressure changes, nasal dryness, the septal perforation, chemical abuse like cocaine, nasal sprays, ammonia, and mass lesions, tumors can be benign or malignant, and some inflammatory conditions like rhinitis and sinusitis can also lead to epistaxis. The other systemic causes like coagulopathies, anticoagulant usage, anxiety, hemophilia, von Willebrand is very common, platelet defects, and hepatic insufficiency, scurvy, hemorrhagic fevers like dengue, Ebola virus disease, and then the granulomatous conditions of the nose like vaginous granulomatous, mid-face granuloma, sarcoidosis, syphilis, tuberculosis. You can enumerate the list like anything, so you can fill 2 pages just with etiological causes. Whatever comes to your mind, you can just scribble it out so that you get a very good list of systemic causes and the local causes. And never to forget this one, Osler-Weber-Rendu disease or the hereditary hemorrhage telangiectasia. I myself personally have seen 3 to 4 cases of Osler-Weber-Rendu disease, and it's very common. It's not uncommon. Okay, so you can list out the cases of etiological factors and what are the investigations you are going to do. First one is taking a very good history because epistaxis, the patient is always in the emergency ward or in the ENT OPD setup, we are not going to we have to control the bleeding rather than taking him out. So you have to have a very, very good history and very, very crisp in very less time. You have to get all the history of it, any previous similar episodes, or this is the first time, and then the clinical examination of whether the epistaxis is anterior or posterior. It might be an anterior epistaxis or a posterior, but that is very difficult to assess when the epistaxis is there and the whole patient is pulled in with the blood. It runs like as if you had opened up tap water, okay, many times, and it is very panicky and a scary situation where the patient sees the blood in front of the eye, so he is also scary. The attendants who are seeing the blood, they are also scary, and the doctor who is attending, he is also scary. So it is, so you have to make the attendants cool, you have to make the patient cool, and before that you should be very cool to attend this patient actually. So a good amount of clinical examination, just put an anti-rhinoscopy, just see where the bleeding is, whether it is active or not, put a suction and over through that, and then be ready with the pack. That's it. So you pack the anterior nasal cavity. If the bleeding stops, well and good. If it is not stopping, then you have to do a posterior nasal packing. Posterior nasal packing is the patient won't tolerate with the posterior nasal packing when he is very much in consciousness, but we can use the Foley's catheter. You can inflate, you can put the Foley's catheter through the nasal cavity, inflate the balloon and just pull it so that it blocks the posterior part of the posterior corner, so that you get a very good amount of hemostasis there. So then you send the blood investigations, you uh, give importance to the bleeding and the coagulation profile, and then put a blood grouping and typing has to be done. Put the blood in demand, whatever the group or the type. If the patient has lost more than 200 ml, just check his hemoglobin. If it is less than 8, then there is no doubt you have to transfuse him, and then go ahead in going and imaging him. So if possible, when there is no epistaxis, when there is no active bleeding, you can go ahead in doing a nasal endoscopy and see from which part of the nasal cavity it was bleeding. But if you are not able to do that, then CT scan will show you whether there was any mass lesion or any other uh, etiological factors which was responsible for epistaxis. Most of the time you land up with finding no etiological factors, idiopathic. And then endoscopy, I've already mentioned, if you find time, if you have confidence that the bleeding is not active, then you can do the endoscopy. So management, this is what the initial first aid measures we do, and we control, take the patient under our confidence. So you control the bleeding with a packing, nasal packing, and then you can do whatever you want. So first of all, you make the patient stable, you make the stop the bleeding. So and then you can go ahead in investigating it. This is the, because it is an emergency, so you have to act as fast as possible. So medical treatment doesn't hold a big deal here, because tranexamic acid and vitamin K do have some minimal role, but we usually give once we see the patient in epistaxis, we just start with the tranexamic acid and a shot of vitamin K, and management is purely surgical. You remove the nasal packing after 48 hours and see for the area, and under general anesthesia, take him and examine him, put an endoscope, and try to visualize from which part of the nasal cavity it was bleeding. And if you can find the active bleeding site, you go for cauterization. You can cauterize it with a chemical uh, one, or you can cauterize it with diathermy. So, yeah, chemical cauterization or electrocauterization. Chemical cauterization, which chemicals do you use for cauterization? It is one of the question for you for this one. What is it? Viva. Any guess? Yes. silver nitrate, and you can use acetic acid, 2% acetic acid. So that's how we do a chemical cauterization. Or if you don't have a chemical cauterization, if the patient is under general anesthesia, you can use a diathermy, the electrocautery. Sometimes we do a septoplasty if the septum is bleeding, if the Little's area is bleeding very much, we can do a septoplasty. If there is some any lesion, you try to address the lesion. And even if most of the cases you can't control the epistaxis, like the patient will be okay for 24 hours, but after 24 hours suddenly he will start again to bleed. But here what we do is then you go in ligating the vessel. Obviously you have to ligate the vessel which is bleeding. See, imagine if there is a leak in the water, so either you have to put a pressure over the tap or a pipe to stop the water from coming outside, or you tie the tap so that the water doesn't come in this side. That's all. So pressure is nothing but putting cautery, putting a nasal pack, and other things, chemical cauterization. To ligate, you have to see which vessel is bleeding. So that's why we read about the blood supply of the septum and the lateral wall. So when you go and when you go in ligating, we start from the external carotid artery, which is the main artery which comes and supplies the throat, the nose, and the ear. So we usually ligate the external carotid artery, leaving the first branch of the external carotid artery, the superior thyroid artery, and then ligate it. But sometimes you can go ahead in ligating the internal maxillary artery also, to be precise, because the nose sphenopalatine artery is the major supply, so which is a branch of the internal maxillary artery. Internal maxillary artery can be ligation can be done as an open procedure, or it can be done as an endoscopic procedure also. And this ESAL is nothing but endoscopic sphenopalatine artery ligation, which can be done endoscopically. Go find the middle turbinate, and posterior to the middle turbinate, you find the sphenopalatine artery and you ligate it there. Or you can do an embolization. You can find and you can give the contrast, see for where the bleeding is, and embolization is usually done by the interventional radiologist. Okay, and if you have the luxury of laser, then you can even use laser for cauterization, or to cut any mass or a lesion which is bleeding. Okay, so that gives a um, precise cut over it, and cauterization also when you use a laser. So that's how the epistaxis is managed. Okay, so the to just gain some few points, you can add what are the complications or sequelae with epistaxis treatment. Actually, there can be synechiae, because you might tend to injure the lateral wall, the turbinates, and the septum, and over the time of healing, it can adhere to one another and forms a synechiae. Okay, or septal perforation after the once you do a septoplasty for epistaxis, and if you had removed the cartilage and there was a tear on both the sides, you get the septal perforation. And rhinosinusitis, because due to the regular packing of the nose, you get rhinosinusitis. Toxic shock syndrome, when you leave the anterior nasal packing for a long time, then you have this one. Eustachian tube dysfunction can do also occur due to the packing. And scarring of the nasal ala and cardomella, when you try to pack both the sides, and then if you have connection in of both the uh, anterior nasal packing, which is very tight enough to produce a scarring of the columella, so it can give a columella dip also, necrosis. So these are the complications. Just to score some extra points, you can write these one. Okay, the next one, which is very 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 uh, much repeated, is juvenile nasopharyngeal angiofibroma. It is always asked with a small note on epistaxis, and then you get this juvenile nasopharyngeal question as a second half, or it can also be asked as a essay completely. Okay, so JNA, as we all know, can be framework again can be stratified under introduction. It's a disease, right? So introduction, incidence, etiology, clinical features, investigations, histology, staging, and then management. So introduction, it is a rare, highly vascular tumor affecting mostly adolescent males, and it's benign by histopathology, but it is considered malignant by location, local invasion tendency, and the possibility of recurrence. So everything is a point on its own. Highly vascular tumor bleeds on touch. The moment you touch, there's bleeding, and it affects mostly the adolescent male, the teenage male with a mass inside the nasal cavity. Nothing should strike you. It's a JNA. Okay, it's benign by histopathology, but it is malignant by location because it's not a malignant tumor, but it is benign, but it can spread. It can locally invade into the sinus. It can go into the nasopharynx. It can go into the orbital cavity and even the intracranium also. And most significantly, it can recur. Recurrence is very, very, very common. The recurrence rate is 50%. So it typically affects the adolescent males. Females, very, 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 very rare. And if you find any female patient with juvenile angiofibroma, nasopharyngeal angiofibroma, then it's a case to be reported. And intracranial extension due to the local invasion is there in 10 to 20% of cases because most of the cases they present in the later stage. So the etiology is given by various theories of juvenile nasopharyngeal angiofibroma. The Ringer's theory, where the origin is said to be the periosteum of the skull base. The Sohm and Nepson theory, where it is stated that the hypertrophy of the periosteum in response to the hormonal imbalance develops as a angiofibroma. And Ewing and Ben said it arises from the embryonic fibrocartilage between the basic occiput and the basic sphenoid. So there were various theories. Just mark the names of the theories. It will be, if it is asked in the essay, you have to write it, or if it's more commonly asked in your OSCE and even in your Viva. So, because old timers are very, very, what to say, fond of asking the theories of juvenile nasopharyngeal angiofibroma. Okay, so the other theories are given by Martin et al., Osborne, Stemberg, and this. Okay, histology, it is the name itself says it's a angiofibroma. So it has both the angiomatous component and the fibro component. So both of them mixed. The arrows are show the blood vessels inside that. So it is a highly vascular tumor with a compact fibroblast and the blood vessels and the connective tissue which is there, and they give a line. That's why it bleeds on touch. The moment you touch the bone, touch the tumor, just bleeds, and it is due to this um, smooth muscle, which is or the elastic fibers, which contribute to the tumor's capacity for the massive hemorrhage. And clinical presentation in anterior rhinoscopy, you see a sessile, smooth surfaced pinkish ovoid mass occupying might be the entire nasal cavity, which is growing posteriorly to the nasopharynx. Once you see the posterior rhinoscopy, you find a mass coming out through the posterior corner, and this mass bleeds on touch, very, very characteristic. And then if it involves in the later stages, if it involves the intracranium or the orbital part, it gives to proptosis. And this is just a figure to show you the frog face in the advanced stage of the tumor. So in the physical examination, it's a male adolescent, mucopurulent secretions in the nasal cavity, and the soft palate is often displaced inferiorly, or a pinkish reddish mass you can find there, and a smooth lobulated mass in the nasopharynx. This is classical of the juvenile nasopharyngeal angiofibroma. So what are the other symptoms which you can? Swelling of the cheek, hearing loss due to eustachian tube dysfunction, dacryocystitis when it affects the nasolacrimal duct opening, rhinorrhea, and when it has an intra cranial extension, hard and soft palate deformity because it goes to the nasopharynx, so it causes pushes over the soft palate, and hyposmia, anosmia because it goes over, goes to the roof and where the olfaction area is present. And some advanced lesions may have proptosis, so you have diplopia, visual loss, facial pain, and trismus. So coming down for the investigative procedure, investigations mostly the diagnosis is clinically it is you can get 100% that it is a angiofibroma, but to know the extension of the disease and to know what are the structures involved by this tumor, you have to do a CT scan. The CT scan should be contrast enhanced CT scan. So you get a classical finding, the sign of, can anyone guess what is the sign here? The anterior bowing of the posterior wall of the maxillary sinus, which is known as the Allman-Muller sign. Okay, so the CT scan you can find the extension of the disease, where it is extended, and what are the structures it is involved. And the Hallman-Miller sign is a classical finding in the CT scan and in the X-ray also. But in the MRI scan, you get more of a soft tissue window, not the bony breed, so that the soft tissues, whichever soft tissues it has involved, that is more very much important when there is an intracranial extension, we do a MRI. When there is an orbital invasion, we do an MRI. And it has a characteristic salt and pepper appearance in the MRI. Okay, and angiography is done along with the imaging. It can be a MR angiography or a CT because we have to identify the main feeding vessel of the tumor. Why we have to identify the main feeding vessel of the tumor? Because we have to do a pre-operative embolization. Some surgeons are in favor of pre-operative embolization. Some surgeons are not in favor of pre-operative embolization. So they say that if you do the pre-operative embolization, the vascularity of the tumor shrinks and even the size of the tumor is reduced, and it is very easy to dissect and remove the tumor. Some surgeons say it is not only one single vessel which is feeding the tumor, so it might be due to, it might be two or three feeding vessels. So embolizing one feeder is not of any use. And another thing, once the embolization sets in, the tumor shrinks and we uh, tend to lose the plane of the tumor because it gets fibrosed in the next 24 hours. So there is a method of staging. The many staging methods are there, starting from the Radowski, Fish, Andrew Chandler, Jones. So the most commonly used is the Radowski staging, and it gives how far the tumor has extended into the nearby structures. Fish staging is also very much useful, but Radowski staging was found very useful for the surgeons because it gives a clear picture about what is the extension of the tumor, so that the surgeon can easily uh, compare two or three of cases with other people. So that's good for them. Okay, so Radowski, Fish, Andrew, Chandler are the four staging systems. Uh, Even if you don't know the staging, at least try to remember the names of the staging. And if you are if you are able to remember the staging, then you can give. But it is very, actually, if you read the staging process, it's very easy to bypass it because when it is there inside the nose and the nasopharynx, then nose and the nasal cavity and the nasopharynx, it is one. Okay, when it is involving one or two sinuses, it is 1B, and if it goes into the pterygopalatine fossa, it is 2, and if it goes very much into the pterygopalatine fossa, it is 2B, and when it is there into the infratemporal fossa extension, it is 2C. Okay, and anything into the skull base, it is 3A, and anything into the cranium, it is 3B. That's it. It is just a layer by layer, so step by step. That's it. How it is extending. And treatment part, already we had discussed about the pre-operative embolization. Okay, it is mostly the controversial thing is it's not a single vessel which is supplying the tumor. And then we have the hormonal therapy. Hormonal therapy, because it is stated that it is due to some hormonal imbalance in the teenagers, you get this angiofibroma. So anti-androgenic drugs like flutamide have been tried, and estrogen have been tried for reducing the size of the tumor. And radiotherapy is given to decrease the recurrence, and 30 to 35 fractions, that is have been tried the uh, in the post-operative period also. The other is the surgery is the only gold standard procedure, and surgery can be done as an open procedure or as an endoscopy. Open procedure, you have various approaches: the transoral, transfacial, transpalatal, craniofacial, lateral rhinotomy, and the degloving approach, mid-facial degloving approach. There are so many approaches by, by which you can do the surgery. So the differential diagnosis of might be asked as a part of the epistaxis, or as a part of unilateral nasal obstruction, or as a part of nasal obstruction. Question: mass in the nasopharynx. Then you can give this one DD for a nose and the nasopharynx, hemangioma, antroconal polyp, nasopharyngeal carcinoma, angiomatous polyp, nasopharyngeal cyst, hemangiopericytoma, rhabdomyosarcoma, and cordon. The slide I just include because in case if you get any case that what are the causes or differential diagnosis of a nasopharyngeal angiofibroma, then you can give very well this one. The next major one is the nasal polyposis. Okay, I think nasal polyposis you would have read in and out, and because it is a case for you in the clinical examination, and it can turn out to be your uh, long case. So you should know very well in and out about nasal polyposis. So we'll just rush through about the nasal polyposis. So what are the subheadings? The types, etiology, clinical features, investigations, and management. This is very, 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 very commonly asked both in the clinical examination and in the written examination. Antroconal polyp and the ethmoidal polyp, the differences between them. Just by heart it, you might be asked in your clinicals, you might be asked in your essay. And if not asked in your essay, it might be in the viva. If not in the viva, it might be in ASCII. If not in ASCII, it might be in your written exam. So it's very, 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 very important. Antroconal polyp and the ethmoidal polyp. You just start in this manner. Okay, like first, what do you ask the patient? The age. Okay, antroconal polyp is common in children. Ethmoidal is an adult. Okay, and then come to the clinical examination. Antroconal polyp is single. Ethmoidal polyp is multiple. Antroconal polyp is unilateral. Ethmoidal polyp is bilateral. And then antroconal polyp, androconal. So it originates from the maxillary sinus. And ethmoidal polyp, it originates from the ethmoidal sinuses, the middle turbinate and the middle meatus. And growth, the antroconal polyp grows backwards to the corner, and the ethmoidal polyp might grow, mostly grows anteriorly. And the size and the shape of it, antroconal polyp is trilobed with antral, nasal, and conal parts. And the ethmoidal polyp are grape-like structures. Recurrence is very common in antroconal polyp, but in ethmoidal polyp, ethmoidal polyp, it is common. Okay, treatment both are surgical, but some early part, early ethmoidal polyps can be treated with steroid, which is known as medical polypectomy. So the etiological factors are various. Inflammatory conditions, you might have known everything, Carter-Gardner syndrome, cystic fibrosis, and associated conditions. The Samtus triad, aspirin intolerance, asthma, allergic rhinitis can also lead to formation of polyps. So the clinical features are the smooth, glistening, grape-like structures, pedunculated, insensitive to touch, does not bleed to touch, and the management is nothing but diagnostic into the nasal endoscopy. You clearly see what it is. So clinically diagnosed, CT scan gives you the picture of what are the sinuses involved and gives you a roadmap for the functional endoscopic sinus surgery. And then medically, you can give nasal steroids, nasal steroidal sprays, and then systemic steroids you give in low doses to make the size of the polyp to reduce, and antihistamines. And surgically, you do functional endoscopic sinus surgery or the transnasal ethmoidectomy or the transantral ethmoidectomy. The next one is the rhinosporidiosis. Most of the time it is a short note, but in case sometimes it is asked as part of a question in epistaxis. The same thing, rhinosporidiosis is a disease or a condition. So what else you want? The headings are like this: introduction, etiology, pathogenesis, clinical features, management. So introduction, it's a granulomatous disease affecting the mucous membrane, not only of the nasal cavity, it can affect the oral mucosa also, it can even affect the larynx and the trachea also, and the pharynx also. It is caused by the Rhinosporidiosis seaberry, which was considered as a fungus, but now considered as a protozoa, and it is a waterborne disease. Those who go and take bath in the ponds and the lakes, so develop this disease. It is more common in Sri Lanka, southern states, districts of Tamil Nadu like Madurai, Ramnad area, and more common in male population and within the age group of 15 to 40. And it has a classical mode of spread as auto-inoculation, direct transmission, hematogenous spread, and very rarely lymphatic spread. And write down about the life cycle of the Rhinosporidium seaberry. Might be asked as a short note also. Okay, so imagine this diagram where the endospores, so the spores are the infective part which develops into a trophocyte and then into an intermediate sporangium and then forms a mature sporangium which bursts to release the spores. Okay, and then comes the histology where you find the spores inside the thick walled sporangium and then the lymphocytes. Sometimes you might be having a slide on rhinosporidiosis in your clinicals. So this slide may help you in distinguishing the rhinosporidiosis. So clinical pictures: nasal obstruction because it's a mass inside the nasal cavity, epistaxis classically, and you see a strawberry-like soft polypoidal red mass, okay, with white spots over it, which are nothing but the spores of the sporangia, which are the infective part, and it is painless and bleeds to touch. Bleeds to touch. Okay, and what is the treatment of it? Is medically you can do dapsone, give dapsone 100 milligram OD for 6 months. They have tried, and surgically the surgery is the treatment of choice, where you do cauterization of the root, excise the rhinosporidiosis with the cauterization of the root. You can use a laser, you can use a coblation, and uh, the root has the recurrence is very, very common in rhinosporidiosis. The other unlucky question, I would say, is a nasopharyngeal carcinoma. But when you get a carcinoma, I think it is very easy. It is a very easy question because carcinoma. Imagine carcinoma, any carcinoma for that matters. Etiology is smoking and drinking. In spite of that, you may add sometimes a virus or some additional factors, like in nasopharyngeal carcinoma you have Epstein-Barr virus. So etiology is done. Okay, and then what are the signs and the symptoms? If it is a nasopharyngeal carcinoma, obviously you will have obstruction of the nasal cavity, bleeding sometimes, and nasal discharge, and it can lead the nasopharyngeal carcinoma arises from the fossa proximal, so it may affect the eustachian tube, so you can have a hearing loss. Okay, so and that's signs and symptoms. So how we are going to classify it? Classification: it is a keratinizing squamous cell carcinoma, and investigation: it is an endoscopy
and then you do imaging to know about the extent of the disease and to know about how far the disease and to know the staging of the disease, and then treatment. All the carcinomas has only three treatment: surgery, radiotherapy, chemotherapy. Yeah. So any carcinoma you can blindly attempt with these things: etiology, clinical features, investigations, staging, and treatment. If you even if you don't know the staging, just write T, TNM staging is done. So it's very easy to remember. So that's what I told. Originating in the posterolateral nasopharynx, or the fossa of Rosen-Miller, common in males, and here Epstein-Barr virus was the etiological factor which will be added with smoking and alcohol consumption. So classification is WHO classification 1, 2, 3. Squamous cell carcinoma, it's mostly, and 2 is non-keratinizing, 3 is undifferentiated carcinoma, and clinically it's a mass in the nasopharynx. So you can right, what you can just imagine was what mass in the nasopharynx will cost, and then imaging, and then you do the staging. Biopsy, you get the squamous cell carcinoma. Biopsy usually done under general anesthesia, where we do endoscopically. We take a small tissue from the tumor, and the treatment: radiotherapy and chemotherapy are the mainstay of the treatment. Surgery we don't do for nasopharyngeal carcinoma, but in recurrence cases or in very small cases, we do surgical excision. And the same thing I told, it looks complicated, but it's the very, very easiest question I would suggest to answer. Carcinoma maxilla. So what are they? Introduction. You can write carcinoma maxilla arises from the maxillary sinus, most commonly from the anterior wall or from the lateral wall of the nose, that is the medial wall of the maxillary sinus. Okay. Etiology. What are the etiological causes? Smoking, alcohol consumption. You can blindly cue, but in extra to that, addition to that, you have persons who work in wooden factories, the persons who the sawdust and the wooden dust particles, they produce carcinoma maxilla. And then those who work in nickel chromium factories, they also develop carcinoma maxilla. So that is an additional point. That's it. Then go ahead with clinical features. A mass in the maxillary sinus, what would it cause? Sinusitis. Okay. When it comes out through the cheek, it can invade the nerve here, so you get a numbness over the cheek, or you can get a swelling over the cheek. When it goes posteriorly, or when it involves the lateral wall of the nose, you have sinusitis features. You can, and then pain. Okay. And then loosening of teeth. Okay. So these are the clinical features you have. And then diagnosis is you clinical diagnosis by endoscopy. You can find the mass arising from the lateral wall of the nasal cavity, or you do a imaging CT scan. Okay. And then treatment: radiotherapy, chemotherapy, surgery. That's it. Surgery is excision. You can do a mid-phase degloving, or mid-phase degloving, yes, or you can do it transoral, or you can even, if it is a very small tumor, you can even put an endoscope through the nasal cavity and go. That's known as the Dunker's approach. But you can give surgery, endoscopic, and open approach. Okay. So done. So that's what I say. The question may look very difficult, but any carcinoma can be dealt in this manner. You can easily do that. Carcinoma maxilla, I forgot about histology. Histology is mostly the squamous cell carcinoma. Sometimes it might be adenocarcinoma. Okay. And the surgery which was asked in many questions was septoplasty. So septoplasty, it's a surgery. So if you know the introduction and history, you can give it. Otherwise, for all surgeries, you have to write indications. What are the absolute indications and what are the approaches? Like a septoplasty is done as an approach for a pituitary tumor. So you do a septoplasty, you reach the sphenoid sinus, and then you address the pituitary tumor. So that's how it can be an indication as a part of some other surgical procedure. So it can the approach for a
pituitary tumor, endoscopic approach for a pituitary tumor is a septoplasty. So absolute indications, what are the absolute indications? It is deviated nasal septum, rhinosinusitis, or you're doing any fist surgery, and if you have a deviated nasal septum, to get good amount of space, working space, we do a septoplasty, correct the septum, and then we do the fist. So it is an approach. It is a part of the surgery. Okay. So the absolute indications are deviated nasal septum, septal abscess. It's one of the another major absolute indication. Okay. Contraindications of the surgery, bleeding disorders, or any other relative contraindications. So there is no absolute contraindication of doing a septoplasty. Usually we don't do it in the very small kids. Okay. And the complications, all surgeries. What are the immediate complication, late complication? Immediate complication, bleeding. Okay. And injury to the other structures, neighboring structures. What are the late complications due to the healing process? It can be again still a bleeding due to the reactionary bleeding. It can be due to any infections, okay, or due to the healing process. There can be any synapse formation, or there can be septal perforation, or saddle nose deformity due to the inappropriate removal of the cartilage, okay, or tiptosis, okay, due to the improper cartilage removal. Okay, and what are the types of septoplasty? It can be done in a conventional procedure, or it can be done as an endoscopic procedure. That's all. So what is the difference between submucous resection versus septoplasty? Submucous resection, even I had never seen a submucous resection in my days. So septoplasty and submucous removal still remains a topic for the old timers. If you get an old timer examination, they do ask this difference. Okay, so be prepared and just mug it up. Only 9 points, easy to understand, and you can go about and telling this. Okay, submucous resection is a very radical surgery compared to the septoplasty, and it is not done in children. And we use a Killian's incision for submucous resection, whereas we use a Freer's incision for septoplasty. Okay, and the flaps are elevated on both sides in submucous resection. In septoplasty, we elevate on only one side. Most of the cartilages are removed in submucous resection. Less cartilage is removed from septoplasty, and the caudal dislocation is not corrected in submucous. Caudal dislocation is the anterior part of the columella or the nose. Okay, and chances of perforation is higher in submucous resection, and the complications are usually higher in submucous. So the caudal dislocation, perforation, saddling, everything is more in submucous resection. Okay, so if you are very having a very bad time, and if you are really unlucky, then you can get this guy allergic rhinitis as a nesse. Okay, for the postgraduates, yes, it's a very good question, I would say. But for the undergraduates, still you can go ahead and writing this one, because it's very easy, because you just have to understand the topic. That's it. Allergic rhinitis, you have to give the introduction about the things, classify the allergic rhinitis in mild, moderate, and severe, and it is classified according to the severity: mild, moderate, severe, and seasonal or perennial. If it is uh, throughout the year, then it is perennial. If it comes in seasons, then it is seasonal. Okay, so that's how it is classified. And the pathogenesis is very easy. It is the type 4 hypersensitivity reaction. If you are very clever in pathology, you can just replicate the type 4 hypersensitivity, whatever is, you know, not the type 1 hypersensitivity, atopic reaction. So you can just replicate that one. And the clinical features: rhinitis, sneezing, itching around the eyes, itching inside the nose, run mucoid discharge or a watery discharge. Okay, early morning headache and congestion, and redness of the eyes. These are the clinical features. Diagnosis is clinical, and there is no gold standard thing, but you can still go for skin prick test. You can go for RAST, radio assay sorbent test, and then
treatment part, you have the medical treatment only. So you can do, um, you can give steroids, you can give steroidal nasal sprays, you can give antihistamines, and then we have immunotherapy also can be tried in rhinitis. So I think this topics can be explained in detail so that you get some 4 to 5 pages. So I think you can answer that question as well. And hope you had a good time. I had tried to cover most of the essays. These are the actual essays in notes. The rest others or more short notes like rhinopyma, rhinoscleroma, or nose doesn't have a variety actually. The topics are very similar. Most of the time, if you have any question on the nose, symptoms are usually the nasal discharge, the nasal obstruction, epistaxis. So those are the common things. You just remember the history taking, and then you can, even if you doesn't know, you try to give the answer to the question. You try to answer it so that if you know the subjects, it is very easy that you can try to answer. That's what I'm telling you. Just remember what is the question, and if it is a disease, then you can understand that how how far you have read it. So it is very easy to just what to say, reproduce it in your paper. So I uh, I think you guys will come out in flying colors once you give the exams. Hope you do your best. And for any queries, you can raise your comments. I would love to uh, share with you many of the things. Okay, even if you want any resources, I can share you the resources. But most of the things are available in the net. It is very vast, and many people are there. There is a Telegram group where you get all the books. It's only the time we don't have the time to read everything. Okay, so be choosy in reading it, and read only from the standard books, not from the other books. Okay, so prepare well and do good in your exams, and hope to see you guys in the final year soon. Thank you. Thank you.